conservative surgical pain management with addiction medicine, which we find very challenging, and we find it also not small population from ENT patients who sometimes abuse and inject their neck, or come from for other surgeries if it's reconstructive or plastic surgeries. I do not have any disclosure to have. Now, if we speak about the background of the state of epidemic of opioid use disorder, as I'm sure aware of that, we have a crisis or issue with the opioids abuse, and even though in the last 5 years we've been fighting this trend, actually the numbers are only increasing. And for instance, in 2021 we had more than 100,000 overdose deaths in the United States. If we're looking about the cause of, or what the medication which or the compound that leading to this overdose death, the most common one is the synthetic opioids, the fentanyl, which is unfortunately very cheap to buy and prevalent everywhere in the United States. Now, if we're looking a little bit more closer on our city, on Baltimore City, where the Johns Hopkins Hospital is located, in 2018 there were more than 800 overdose deaths in the city itself, and in 2020 it raised to more than 1,000 overdose deaths. And more than 90% of these fatal overdoses were related to the opioids. Actually, Baltimore is the highest age-adjusted overdose fatality rate of any U.S. city, and about 1 in 3 of these overdoses are occurring in East Baltimore. This is exactly where Johns Hopkins is located. Now, as a result, at Johns Hopkins Hospital, there has been an increase in hospitalized patients with diagnosed of substance use disorder. In 2018, it was to about 15%, and it basically raised up to more than 20% in 2020. If we're looking about what is actually substance use disorder, it's a treatable chronic relapsing disease in which substance use is associated with impaired control, social impairment, risky use, and withdrawal tolerance, which actually is only important in cases of abuse. The morbidity associated with that is high, leading to trauma, suicide, homelessness, infections, and if it's HIV, hepatitis C, soft and skin and soft tissue infection, which again, this is the most common where we see them or interact with ENT patients. If they have neck infections or abscesses there, in other infections are osteomyelitis and endocarditis. If we're looking on the diagnostic and statistical manual, number 5 of diagnosis of opioid use disorder, basically it's 11 parameters that take into account. 2 of them are irrelevant if basically these opioids are prescribed. The higher the number, the more severe the condition is. When we're treating opioid use disorder, we have the medication, the methadone, the buprenorphine, the naltrexone, and I'll speak a little bit more about this, the buprenorphine particularly, because this led to the most conflict with the addiction service treating pain. Other treatment which are even more important are psychosocial, behavioral treatment, community-based peer support, and we have the ASAM level of care, which can be in outpatient as well as an inpatient. Looking more about the ASAM, which is the American Society of Addiction Medicine criteria, which is the most widely used and comprehensive set of guidance for placement, continued stay, transfer, and discharge of this patient with addiction. We see that there are different levels of treatment from outpatient to intensive inpatient care. So let's go to our experience. Until now, it was just the background. So our experience is that the Johns Hopkins Acute Pain Service has been treating an increasing number of patients who suffer from substance use disorder, as I mentioned. The APS manage surgical pain with limited focus on their addiction. This has led to suboptimal pain control, missed substance use disorder diagnosis, and basically recovery opportunities. As well as we also potentially increase the risk of overdose death upon discharge. And this happened because we treated their pain, but we treated them with less opioids that they used to take. And basically, when they were discharged, they resumed their old habits and they overdose death and kill themselves. To address the increasing need for inpatient addiction service at our hospital, a new inpatient addiction medicine consultation service was established in July 2020. As a result, both APS and addiction started jointly managing patients with the diagnosis of substance use disorder perioperatively. Now, traditionally, APS focused on managing the acute pain, and addiction consult was focusing on addiction. And sometimes these plans were incoherent. Subsequently, the APS and addiction consult have shifted into collaborative comprehensive management. Now, our effort has have led to a remarkable improvement in all the aspects of care for these perioperative patients. Second. Now, what are potential challenges that we had? One thing is unknown tolerance, which makes it difficult to know how much opioids these patients require to manage their pain, as well as avoiding withdrawal. Other changes is using or managing buprenorphine. And again, I'll say more about that in the next few slides. The third potential change is that opioid use disorder medications were clearly managed by addiction team, though who manages the rest of the opioids was not always clear between the teams. And lastly, in addition to coordinating the in-hospital care, not less important, even maybe more important, was coordinating post-discharge opioid management for the opioid use disorder as well as for their pain. The potential positive collaboration outcome that we hope to see, and we're studying it now, is that we believe that by this collaboration, we're actually saving lives by initiating the medication for opioid use disorder, specifically the buprenorphine, methadone, or naltrexone. Another one, we believe that by collaboration, we managing the pain better, and financially, we believe that it leads to shorter hospital stay. If I'm speaking about medication for opioid use disorder as saving lives, there are multiple sources that indicate that treatment of opioid use disorder with methadone, buprenorphine actually decreases the risk of overdose-related death and basically all-cause mortality. Now, some studies show that hospital or emergency department initiated buprenorphine is associated with lower rates of other opioid use and increased engagement. And in general, the use of this medication leads to lower rate of other opioid use, improved social functioning, decreased injection of other drugs, reduce the infection rate of HIV or hepatitis C, and actually improve quality of life. So that's why it's so important to catch this patient when they come into the hospital to manage something else and trying to engage them into rehabilitation and to be treated with this medication which can help their life and change their life. Now, as I mentioned, buprenorphine. Buprenorphine is actually the first thing we had friction with the newly established addiction care in the hospital. So buprenorphine is an opioid which is used to treat opioid use disorder, acute pain, and chronic pain. Buprenorphine was patented in 1965 and approved for medical use in the United States in 1981. Now, sorry, it can be used under the tongue, in the cheek, by injection, or skin patch, which is basically mostly for chronic pain, or even as an implant. It can come as buprenorphine itself or with combined with naloxone to avoid the abuse of the buprenorphine. Now, if we're looking about the pharmacodynamics of buprenorphine to explain more about it. So pharmacodynamic-wise, buprenorphine has a very high affinity to mu-opioid receptors, which basically explains that it is 40 to 70 times higher potency compared to morphine. In a second, I'll explain what it means, the potency. It's not meaning that it's more analgesic effect, it's potency. And at the same time, it is a partial agonist. Now, it does not necessarily reflect as better analgesic. So an analogy that I like to use is thinking about opioid receptors as switches on the wall, and depends what turn on the light. If it's buprenorphine, the turn light is dimmed. However, when morphine lets us switch on the light, it's a full bright light. But because the high potency, if I give the same amount, let's say I'm giving 1 milligram of buprenorphine, 40 to 70 times more receptors are activated, but all of them are dimmed light compared to only one receptor. Do you hear me? Excuse me? Was there any question? Excuse me?
No, you can.
It's okay? Okay.
Yes,
so
you can go ahead.
Okay, so basically, when we have buprenorphine, we have, again, 40 to 70 times more lights are turned on, but all of them are dim. So a question, which one led to more light? Basically, the light is the analgesic effect. It's not very clear, not necessarily clear. Doesn't mean that 40 dim light is more than one bright projector, for instance. So this is what is so challenging about this medication, because two problems can happen. One problem is, let's say patient is here, when you see on the right graph here, patient is here with full agonist in his system. It can be from opioid that we prescribe, it can be from opioid they abused. And then we introduce the buprenorphine because it's high potency, it pushes away the other opioids and turns the lights from full light to dim light, leading to withdrawal. But on the other hand, the other challenge is, let's say a patient is on buprenorphine already, and they're coming for surgery, and everything is, all the lights are dimmed light, but the affinity is so high that even if I try to give them full agonist to help their pain, it has no place to work, basically. So it will be to treat the pain. So two challenges with buprenorphine are withdrawal and pain management. So basically all the problems that we afraid of having in this patient. If we speak about the other opioid receptors, about kappa and delta, it has a high affinity, but it antagonists for both of these receptors. But I will not focus on that part. Now, again, let's speak about some examples to kind of clarify this situation. So, for an example, a patient is coming and abusing heroin, and is coming to the hospital. Is here because of the heroin. We give the buprenorphine because he decided to get clean. We trigger withdrawal. Let's speak about something else. Patient comes on a buprenorphine and we cannot treat their pain. So if we speak about withdrawal, in order to quantify withdrawal, we have a tool called COWS, which stands for Clinical Opioid Withdrawal Scale. It has 11 items, which we count. Some of them are very subjective, some objective, and the highest score we have, the worse is the withdrawal rate. symptoms. 5 to 12 hours after immediate release opioid, and with longer-acting opioids, it can last. It can start within 30 hours. It can peak within 48 to 72 hours, and then after 4-6 days, it's getting better. What we find that usually patient tells us the first symptom they feel is running nose and yawning. This is what the first symptom, but it can be very, very severe. And for this patient, it's very important to treat their withdrawals because if they have bad experience with withdrawal during initiating of medication for opioid use disorder, the less likelihood they would like to stay on this treatment upon discharge. If we speak about managing withdrawal, beside of course giving opioids, which will help their withdrawal, treating the symptoms is another thing that we can use. And these patients regularly get an order set of this medication that the nurses can give them based on their symptoms that they describe or tell the nurse that they're having. Now, things to consider when we're dealing with buprenorphine or this patient. Number one, are we dealing with painful situation where we need to give them opioids to manage the pain, or non-painful situation where we don't need to give them opioids? And the other one is, are they coming with buprenorphine and we need to do something about it, change, increase, decrease, or we initiating treatment in this patient that basically patient are abusing, coming to the hospital, and they're interested to get clean and to rehab themselves. So if I'm going for the first perioperative, that this is the majority of the patient that we see, it's a painful situation requiring managing their pain. And the truth, nothing is as effective to treat pain as opioids. So let's speak about the first situation where a patient comes on buprenorphine and they're coming for surgery. What do we do? So previously, in previous years, let's say 5-6 years ago, what we used to do, and this is an example, this comes from University of Michigan, a protocol that they used and has been published extensively. What we were doing, we were telling them to stop the buprenorphine. Even worse, if a patient would come for a painful situation, a painful surgery, and they did not stop the buprenorphine, you can see here, you see cancel surgery. This was one of their options to offer this patient. They were so concerned about their pain control that they would tell them, look, we cannot do the surgery today, we must cancel the surgery. However, what happened was relapse. What they found that when we followed these protocols, patients that came on stable dose of buprenorphine were clean for years, they came for surgery, they were taking off the buprenorphine. Actually, they left the hospital with full agonist opioids and relapsed and never came back on buprenorphine and all the consequences that comes with the abuse of opioids or anything else. So as a result, in almost 2021, the American Society of Regional Anesthesia published expert panel recommendation. Now, again, this is an expert panel and not based on much evidence or research. And another thing to remember, the focus of the purpose of this recommendation was to be as broad as possible, to be applied in basically every setting. And the concern of relapse was very, very high. So what do they say? Let's look into details. Number one, of course, they said to try to use non-pharmacological management or non-opioid pharmacological management, meaning like using all the Tylenol, NSAIDs, anti-neuropathic pain medication, treating muscle spasticity, spasms, etc., as well as using drips that we're using like ketamine or lidocaine drip or magnesium drip, as well as offering them, of course, regional anesthesia if we can do or have that option. However, what's very interesting, what they say here, if I mark it, it says that if it's severe pain, they can even, beside splitting the dose, they said to increase the dose. So in contrast to what we used to do, the most recent ASRA guidelines saying if pain is not well controlled increase the buprenorphine. However, I just told and mentioned that buprenorphine is partial agonist, can block the pain control. So what I see in the hospital when we treat this patient is that sometimes it's enough. Sometimes having all the lights turned on in dim light is enough to treat the pain, but sometimes it's not enough. And sometimes this recommendation, because they focus on preventing a relapse, it sometimes comes in the price of more pain. Likely the truth is somewhere in between, and this is something we'd like to study and to come with more evidence or accurate evidence, but when and how we should keep, increase, decrease the buprenorphine around time of surgery. So if we go into the other scenario where patient comes and he's in a lot of pain and they've never been on buprenorphine, so how do we initiate it? Because we know we need to treat their pain with opioids. So here it comes again from the expert panel. And what they say that it basically, they say, give them buprenorphine. However, the timing is crucial. We give them the buprenorphine when the full agonist opioids is basically start to clear off their system. They developing their withdrawal. So basically, they're around here. So the pain is treating with opioid. They hold it for 4 to 6 hours. They're around this area. They give buprenorphine. They manage their withdrawals as well as manage their opioids. This is a great idea. However, not always very practical because some cases is so painful the patient cannot hold their opioids for even 1 hour, even for a very short time. They must have the PCA or patient control analgesia. They must have opioids ongoing. Some patients also on long-acting opioids. So this idea is not always relevant, and it's always they are somewhere here. The opioid receptor are activated highly. And by giving the buprenorphine, we causing them withdrawal. So for that reason, our addiction team at our hospital working and doing low dose initiation. Basically, what they're doing, they're introducing the buprenorphine very gradually, very slowly, in increasing doses, and by that, they're hoping to mitigate or decrease the withdrawal symptoms. At the same time, we do other things. We give them scheduled opioids. We're treating them with all the PRN or as needed medication to treat the withdrawal symptoms. We treat them with ketamine. We give them many things. So this initiation of buprenorphine would be as comfortable as possible. Now, let's speak about the other scenario when a patient with opioid use disorder comes for a non-painful situation. And this is much easier because the patient are not in pain. They don't need opioids. So we don't have the problem of or the conflicting situation where we need to treat pain and buprenorphine prevents that, or they need to give them opioids and they're going through withdrawal. So here they don't have these opioids. So here what we're doing is this is an example of a protocol from the SAMHSA, which is the Substance Abuse and Mental Health Service Administration. And there are many other protocols that you can find. And basically, they base their initiation of the buprenorphine on a withdrawal. The patient goes through withdrawal, and then they introduce buprenorphine at increasing dose up to the goal. But again, this is not a big problem. If we're speaking about the other one, which is the methadone, I will not elaborate much. Basically, methadone is a full agonist. It does not usually pose a problem, as it will not trigger withdrawal symptoms. And as potent opioid, it's basically as effective, maybe more effective. And this is easy. If patient chooses to do methadone, there is not much conflict in the issue. Another challenge that we encountered when the new service established was who will manage the other opioids. Basically, it was clear that the addiction team manages the medication for opioid use disorder, and that the multimodal analgesia, such as ketamine drip, lidocaine drip, regional anesthesia, was managed by the acute pain service. But the team didn't know who manages the Dilaudid, who manages the other opioids. So we decided that opioid will be managed by the first consulted service to avoid disagreement and actually allowed each team to learn from the other one. And interestingly, this led that after 2 years, both teams are usually in agreement. We agree. We learn from them, they learn from us, and we found a place where both of us are very happy and comfortable with the opioid. Now, discharge is very important and very of care for both pain and addiction. The addiction team assists this patient with post-discharge addiction care follow-up at the appropriate setting based on their needs. Regarding the opioids for pain management, if addiction is managed, we have a service that we run at our hospital. It's called Personalized Pain Program, where we see patients around time of surgery. And we help managing the pain for the period of the subacute up to chronic pain using multidisciplinary as well as multimodal. And if these patients are treated by addiction service, we at our clinic, we see this patient, manage the pain, wean them off the other opioids, and making sure they don't go into relapse. And prescribe them opioids as well, but in a safe manner, so they would not go into trouble. Now, to quantify the impact of the multidisciplinary collaboration, these days we compare various out to the introduction of the addiction patient consult service and after. We believe and we see some signs that the collaboration has brought short and long positive outcome, including saving lives of this underserved and undertreated patient population, and the results hopefully will be published soon. So to summarize, what we learned from this collaboration, this experience at Johns Hopkins Hospital. One, that addiction acute pain service collaboration is very important, though can lead to tension and incoherent care. And as a result, coordinating care collaboratively is very, very important. Now, we learned that each team learns from the other, and over time leads to coherent treatment plans that combines and optimize care to address both pain and addiction. And we believe, and again, we have some findings to show that the multidisciplinary collaborative care improves outcome and possibly saves life by providing the support that this patient population needs during their hospital stay and after discharge. Okay, thank you. Thanks so much for listening. And if you have any question or want to learn more, please do not hesitate and email me to this.
Thank you very much. Are there any questions for Dr. Ronen? It was an excellent talk.